Good day, everyone, and welcome to today's edition of the ICFJ Global Health Crisis Reporting Forum's series of webinars that are geared towards expanding journalists' knowledge base regarding the COVID-19 pandemic. I still remember when the pandemic started, the pandemic was more popular than the virus. And but several months and later, we had attention due to new issues of new variants from the Alpha to Delta, and the latest one, which is the Omicron variant. And so the conversations around the latest variant has been one that is, so in some aspects, people describe it as very, very serious, very, very deadly, dangerous, and easily transmissible. And another set of conversation talks about it in the fact that it is less lethal and it is less serious. So there seems to be confusion, and maybe this is due to the early nature of the variant or to the kinds of news that individuals listen to. So as journalists, the role of journalists is to present the factual information to inform the general public so that the right decisions can be taken. But when journalists are not well equipped or well armed with the right information, then this becomes extremely difficult. And that is why we are start having this conversation today, which is aimed at providing the fact-based knowledge, what we know so far about Omicron. And if you've been following the conversations around Omicron very well, you will know that South Africa is at the epicenter, is at the forefront of knowledge, of helping the world to close this knowledge gap regarding the strain. And this is why I'm joined by Peter. Peter was here some time ago to help us understand Delta variant. So when the latest variant came up, we had to invite Peter to help us understand the Omicron variant. Peter, how are you doing today? And say hello to our audience.
Hi, Paul. Nice to see you online again. I'm doing quite well, thank you. Although you might see how much hair I've got left from pulling it all out, dealing with all of this new virus news.
Okay, Peter. So before we really before we get everybody on board, I think it's really, really important for us to hear from Peter first about what the science is. And I think it would be really great for him to take it from where he left us the last time. So, Peter, let's have that science leading explanation of the Omicron, and I will come back to do my best in toning it down for the audience.
Thanks, Paul. Let's take it away. Yeah, so previously, I was with you talking about Delta, but let me start again from the basics, okay? So firstly, I'm a bioinformatician at the South African National Bioinformatics Institute, which is pictured here in this building at the University of the Western Cape. And my focus is on pathogens and also on making bioinformatics more accessible in African public health. But let's get into the bioinformatics, okay? So let's start off with this virus, SARS-CoV-2, the so-called coronavirus that causes this disease, COVID-19. And I've got a diagram here taken from Wikipedia showing the spike, the envelope of the virus, and inside here is the recipe, the genome of the virus. That is how the virus knows how to make more copies of itself. So let's look at this genome, and the genome is divided into different genes, okay? So ORF1A, ORF1B, over here we have S, the so-called spike, and here's a picture. This is what the spike looks like under an electron microscope, and then various other genes. So it's about 30,000 letters, 30,000 so-called nucleotides of RNA that make up this genome. This is the recipe for how to make more copies of the virus. So what happens when you're getting infected? So here you are, you're not feeling very well, and the virus is making many copies of itself. So it's making copies like somebody at a photocopier, or back in the days when we used to copy tapes of our friends, And as you make copies of copies and copies, not every copy is perfect. So we notice that here we start getting changes as the virus is copying itself, okay? So here's another picture of the virus. Some of these changes only make a change on the level of the RNA. So they're what we call synonymous. They don't really change how the virus works. Others, what I've got here in red, they actually start changing some of these amino acids that make up the proteins of the virus. So as this thing is multiplying inside this per individual, there's copies being made. And in fact, within this one individual, there's a diversity of viruses circulating, okay? But now when they come and they infect somebody else, there's what we call a bottleneck. So this person passes on a small amount of the diversity of the virus that's inside them to the new person. So we see maybe only this one type with this change, but not the other types gets passed on. And if we look at the dynamics, how much virus do you have inside you? I've got 3 different coronavirus diseases here. Here in green was the original SARS. This blue one is MERS that is still circulates sometimes. But here, the purple one is SARS-CoV-2, the COVID-19. So one of the things that we see is that the amount of virus in you peaks quite early. 2 days after symptom onset, we expect the peak of the amount of virus in you to be there. And then notice over here, this curve starts, actually, this it's not shown on the graph, but this curve is actually starting before symptom onset. That actually the virus is growing quite a lot before you even showing symptoms. That's how we can have people having transmission before they even know that they're infected, which is one of the reasons that the pandemic has got so bad. But so the other thing that I want you to notice is then after this peak at around 2 days, the amount of virus in you rapidly drops off. So most people are only very infectious for a short period of time. Here, they say about a week, 10 days, okay? And then after the period of time, and then your immune system kicks in and hopefully you recover, okay? But now let's imagine that we've got 5 individuals, okay? So A, B, C, D, and E, and each of them got infected with these slightly different versions of the virus. You see these markers, things like that. Now, if we take all of these, we can say, well, which ones are more similar to which other ones, okay? And we can build that into what we call a phylogenetic tree. So we see here that these are very similar. We see here that this one is a bit similar to that one, and these are quite different, okay? So as the virus is being passed from one to another, then the diversity of the virus means that we can organize the diversity into a tree. And that's how we talk about these variants. So here is a picture that I took this morning of the African diversity of SARS-CoV-2. Now, this is just a small part of the amount of infections that have happened on our continent. This is just the ones that have been captured by scientists and sequenced and then uploaded into the databases. But here, you might notice this big expansion called, that is in this kind of teal color. This is Delta. Over here, there's Alpha, there's Beta. These are basically becoming extinct. There's other colors, actually another form of Delta over there. And you notice that this is very fuzzy. It emerged here early in 2022. Sorry, 2021, sorry, losing track of time here. And then it expanded across the continent and it really took over, okay? And then we've got this little red thing over here. So what is this red thing? This red thing is what we call a long branch. This is Omicron. But notice how this Omicron, this whole branch here, is separate from everybody else. This is Delta. Notice how it's diversifying and all these different branches look like a forest here. They all very like kind of diverse and diversifying over months as we first detected and spreads. But we see nothing that looks like Omicron until this thing pops up over here, okay? So where did it come from? I'm not talking about which country, because we only know where it was detected, but how did such a different virus, different strain of the virus, sorry, it is the same virus, but how did such a different variant of the originate without being detected as it was busy evolving? Okay, so the one possibility is that this thing was circulating somewhere undetected. So let us imagine part of our continent, maybe a more rural part, or a lower resource part, where there's just not surveillance going on. But we don't think that this is likely, because people travel and we would have seen something before now, okay? The other possibility is what's called reverse zoonosis, or spillback. So in other words, this virus went from a person into a non-human animal, okay? We know that SARS-CoV-2 can infect a wide variety of different species, from cats to deer and so on and so forth. So maybe this virus went into a non-human animal, it circulated in an animal population, and then it adapted to those animals, and then it came back to humans. We're not sure. It could have happened. And the other possibility is that there was somebody with a long-term infection. I remember that graph I showed you, that the virus grows fast, but then it tapers off fast as well. But if your immune system is not able to clear it fast enough, so maybe you've got a weak immune system, like people on cancer treatment or something like that, then you can have this virus inside you for a long time, and the virus is constantly making copies of itself, and those copies are having these mistakes, and there's this diversity going on. Your immune system is weakly trying to fight it, but you end up having a huge amount of evolution happening within one person, okay? So that's the other possibility about where it came from. That's how such a diverse variant could have emerged seemingly from nowhere, okay? And in fact, what we discovered even more recently, after first discovering Omicron, is that we're no longer talking about Omicron, but we're talking about different chasms, okay? So what I mean by this is, if I go back to my diagram, look at this diversity here. These aren't all identical. They're quite different to everybody else, but there's diversity within there. Then we discovered in a few countries that there is this pattern. This is part of the so-called spike protein, and this is a list of all the changes. So we can see all these Omicron samples, and we can see that they basically all look the same. And then this is looking the same over here, but then what the heck is this? So this is a sample taken very recently, and similar things have been seen in Canada and Australia now. And so before Omicron was called Omicron, it had this technical name B.1.529, and now they're saying that this family B.1.529, there's actually two different types, BA.1 and BA.2. So most of this is BA.1, and that one down there is BA.2. What this means is that not one, but two very strains, very different to what we've seen before, are out there and are now being detected, okay? So perhaps the events that I was talking about, these kind of long-term evolution in somebody that eventually spread out to other people, perhaps these infections happen twice, and there's a reservoir that we haven't yet identified where these two came from, okay? But why are they so different? So we've seen Omicron now around the world. It's spread all over the place. Yes, the epicenter does seem to be in Southern Africa, but that is likely to change quite fast. But what is the big deal, okay? So why do we care about this quite different version of SARS-CoV-2? And we care because of this graph from Gauteng, our most populated province in South Africa. And we see that our fourth wave of infection has grown dramatically. So these were the previous waves, the first and second waves. And then the third wave was pretty nasty, driven by Delta. And this, now remember, we were starting at almost zero, okay? But then it just took off, starting with young people, students at some of our universities. And then how could this be happening? Okay, so this is a picture of the so-called spike protein of the virus. Now, they call it spike, but to me it looks more like a mushroom or a tree. This is the part of the virus of SARS-CoV-2 that attaches to a human cell. So up here, this is the human ACE2 protein. But when the virus wants to get into a cell, it'll come here, the so-called receptor binding domain, the receptor binding motif, that's this part over here, will connect to the ACE2 protein, and then this whole thing over here will start unfolding and helping the virus get into the cell. Now, all of these colored dots are all the different places where Omicron is different to the spike that we've seen before. And that's a lot. That's a lot of changes, okay? So how does this relate to the high numbers we're seeing at the moment, okay? Let's also look at this diagram. It's a bit more difficult to interpret. These are all the changes, and here where it's in kind of a kind of reddish color, then that means we've seen these, we've seen other versions of SARS-CoV-2 have these changes. But over here in blue, what it's saying is that that previously it's looked like SARS-CoV-2 loses these changes, but here they show up in Omicron. So what seems to be happening is that sometimes changes on their own might not stick around in the virus, but when they all happen together, maybe they do give the virus an advantage, okay? An advantage over what, okay? This is from the South African COVID Modeling Consortium, and it shows our estimates of how many people have already been infected by SARS-CoV-2, okay? So if we look at our different provinces, you see that the proportions are rising towards about 80%. We think that after the third wave, the majority of our country has already had some form of COVID-19, which means that the virus is now getting into people who've already built up immunity against the virus. And remember that immunity is mostly attacking this spike protein over here, okay? This thing over here, the so-called N-terminal domain, here around the bit where it connects with the ACE2. So our antibodies would kind of attack this thing. And the virus that will succeed in the South African population, because so many people have had COVID-19 before, is the virus that can break through this immunity. And that's one of the things that worries us quite a lot. When we say break through the immunity, this is from Prof. Alex Siegel's lab. It came out, I think, yesterday or the day before, I can't remember. And if we look at the ancestral virus, so last year's virus, and we look at the amount of that people who were either vaccinated or were vaccinated and also had COVID-19 before, the amount of immunity they had, okay, compared to that older version of the virus from last year. And we look at how it drops compared to Omicron, okay? So this brown one is for people who've been vaccinated with a Pfizer vaccine. This is for people who've been vaccinated and infected. So we see it doesn't drop as much for those people, but down here, it drops an average of around 40 times the immunity drops. This is just from antibodies. I must emphasize this, that this is only the gatekeepers of your immune system. You have T cells and other things as well. Yeah, so, but what does it mean for vaccines? We expect that Omicron might mean that your protection against getting infected might be reduced, okay, from the vaccines. Many experts think, and I would agree with them, that the vaccines are still likely to protect against severe disease, okay? What does it mean for reinfection? So South African monitoring shows an increase in reinfection. People who had COVID-19 before now getting infected again. So there's I will share these slides, but Dr. Juliet Pulliam has done an excellent thread on this. How much reinfection exactly? We're still trying to figure it out. It's early days, okay? But what does it mean for public health? So if reinfection is more common, if the vaccine protection against infection is likely reduced, then more waves are likely, okay? But those waves, the current wave in South Africa, I have to emphasize, has not led to massive severe cases, okay? But it's also a little bit early on to say what's happening. So the best case scenario would be that we have a wave, it sweeps through our population, but it creates less severe disease. However, as I showed in this slide over here, our best protection that we're seeing is from a combination of vaccination and infection. So in other words, vaccines are still incredibly important. But the confusion caused by what's happening with Omicron is likely to intensify the infodemic. So we are facing both a pandemic from the virus and an infodemic from people spreading disinformation about health intervention. So for public health, this Omicron situation is a real challenge. So what else are we missing out there in terms of the evolution of SARS-CoV-2? Okay, so one of the problems we've got on the continent is that diagnostics are inequitably distributed, both between Africa and the world and within Africa. So this is and sequencing is even more so inequitably distributed. So this is the number of samples sequenced by country in Africa. You see South Africa here outpaces everybody else by quite a lot. Kenya is there, there's Nigeria, and so on. What this means, though, because we travel around, is that we are going to see variants eventually. Eventually, the variant will end up somewhere where it is detected by this diagnostics and surveillance system. But it does also mean that there are parts of the continent where we are not going to see what's going on very well at all, okay? So we have a challenge with public health. We have a challenge in terms of communication, and we have a virus whose evolution at the moment seems to be driven primarily by evading our immune system. As I say, that doesn't mean that it's going to necessarily cause severe disease, but it does mean that keeping our population safe from infection is becoming more difficult with this variant. Okay, thank you for your attention. I think that's enough from my side. And I see that the prof has joined us, so I will end it here.
Yes, thank you very much, Peter, for that. And I'm really happy to announce that Professor Tomori is right here with us right now. And so, Prof, thanks for joining us. And I would like you to take it from where Peter stopped by sharing some insights on the field, not just from the bioinformatics aspect that Peter has. That what do you think this new variant is telling us? Because there are hints here, there are already pointers to the fact that this may not be the last variant. So what is the message that this virus is telling the world loud and clear?
Thank you very much. I hope you can hear me. Sorry, my internet here is not that strong.
So yes, we can hear you loud and clear.
Video.
Yeah, it's okay, sir.
Okay then. And sorry I missed most of I only heard the last part of what you're saying. But again, since I'm not talking about the virology, but just the public aspect of it, I think one of the confusions that came up about this Omicron was the fact that the information that first came out from Southern Africa was not really complete, and therefore, when a colleague was talking about misinformation, and that's always what happens when you don't provide full information about what you're doing, and then people fill it up with other things. Let me tell you the stories that came through our own side. When we first heard about it, we had, it was from Botswana, and the people arrived on the 7th or thereabout. These are diplomats, but they refused to name, or they didn't name where they're coming from. I had a colleague in Ghana who said the diplomats were from their country. Another person said the diplomats were from South Africa. And so with the story that possibly came out of, in fact, I think one of the NCDC in Nigeria actually put a point that the people came from West Africa. But then up to now, I'm not too sure anybody knows where those diplomats came from, which led to all sorts of stories. Was it originally in West Africa? Was it in South Africa? Was it in whatever? And then because of the way the stories came out, I think the South Africans have been at it for quite some time before they eventually reported to the WHO. The date of report, and then the people from Netherlands also said they had their own on the 19th or so of November. So what was going on in the interim was that, oh, look, these Europeans had it before everybody. Why are they not listening? I was trying to point out to them that the date that South Africa reported is not the date they found. But people were not ready to listen to that. It was like, no, this is the racism thing. This is whatever it is. It hasn't spread all over in Europe. Now they're putting all the problem on poor South Africa that gave out the information. Next time, the people are going to, nobody's going to provide information anymore, and all that kind of thing. So, and then you remember the South African team came to Nigeria with the president, and there were all sorts of stories. Should he come? Should he not come? Of course, typically our government will not, will not tell you exactly what they are doing about it. Eventually, a few days after I think it was Canada, I reported that they found some Nigerians who came down with the problem. Then we discovered that we had 2 cases, and they said these are people who had recently traveled from South Africa. Now, this became another point of discussion. Was this Ramaphosa's team that came? We told them not to come before. Now we don't know what it is. But up to today, even the federal government has not told us where was the source of the 2 they found. I mean, we're having a problem with Britain right now over, banning Nigerians. But for me, I've always talked to our people that when people don't have trust in your results, this is what you get. I mean, 27 or so, the number which Britain got, were people supposedly who had left Nigeria, with quote, negative results. And if you have that large number, who were supposedly negative, turning out positive, of course, I didn't blame Britain for what they did. Nobody could trust whatever was coming out of the country. The same thing with Canada also. And we made efforts. I mean, we're always pointing out, I'm one of those pointing out that see the way the South Africans are doing their own. They have a network of 3, 4, 5 different laboratories, well-coordinated activities. Why can't we do that same thing in Nigeria? Apart from Happy's lab in a few other labs are also participating in sequencing, but it's totally uncoordinated. And I was aware that one of the states actually sent their samples to South Africa. Another one is linking with somebody from Europe or US or something. So we have a totally uncoordinated approach in Nigeria to sequencing. And I think that is what is leading to some of the lack of trust in the result that comes from Nigeria. And again, to think that one of the labs that is in Nigeria is a WHO accredited, African accredited lab, and is not being used. So this unnecessary rivalry amongst scientists, which is not happening in South Africa, which is happening in Nigeria, are things we need to address. And because they put all of us in jeopardy. The things that affect South Africa eventually, or Nigeria, eventually began to spread to be a thing of a problem for the whole of Africa. So we need to work together, collaborate more among all South African scientists, rather than the kind of things we are doing right now in Nigeria. So sorry, I just thought I should bring that up, and I'm sure it's a matter that we can talk of. I know the WHO has this network, which to me I think is on paper. I was involved together with African CDC in setting up that work. But from that day of the public announcement, I'm not too sure anything really has happened, apart from the good work that is going on in South Africa. So let me stop here. I'm sorry I joined you a bit late, so I wasn't too sure what was said before I came. Over.
Yeah, thank you very much. So before I start asking questions, so if you have any question, if you have any clarification that you would want either of our experts to help you with, please use the Q&A option on the Zoom platform to send your questions. And if you want to use, if you are joining us on the Facebook live stream and you have any question, please put the question in the comment box below the video that you are watching. And so I would like to bring two issues together. I think one that Prof raised, and something that is also very, very important that Peter also highlighted in his presentation, which is the fact that there seems to be I don't know, Peter, can you agree that the science ecosystem did not handle the communication of the Omicron very, very well? And if we look at the information, if you look at the timeline of how these events came together, from somebody that knows how the process of sequencing works, what is the justification for what seems to be these laps in timeline reporting?
Look, yeah, I mean, I have gone in many different directions in terms of thinking about how scientists communicate in the last year. It was done in a very dramatic way. I think that Prof. Tomorry raised some of the important points. So let's look at some timelines. Okay, this first samples that were announced at the press conference at the end of was it end of October already? The were taken, or was it end of November? I'm losing track of months. But anyway, they were taken on the 11th of the month. Okay, whether it was October or November, I can't remember which one it is. Okay, and then the sequencing happened. I think it was November. Okay, thank you. So then the sequencing happened. So remember that the first samples taken were actually in Botswana. Okay. Now, if we look at sequencing in of SARS-CoV-2 on the continent, the average waiting time between a sample being collected from somebody's nose and the sequence becoming available is 1 month. Okay. If we look at many of the samples, we have instances of what I call freezer dumping. They go into their freezer, they find samples from 6-7 months ago. Now they sequence them and they add them to the pot. Okay. Now contrast that what we saw here was the sequencing was done within 1 week, and the data was then released. And in fact, something that I've never seen in my life before happened, that a British scientist looking at the public databases, this is the GISA database, made a comment on the system that we use for tracking new lineages, you know, these B.1 numbers, okay? So he made a comment, and this is on a very technical website. This turned into a newspaper article in the UK within a day, and the Twitter was full of UK experts going on about this new thing discovered. It didn't even have a technical name yet. I've never in my life seen the Guardian newspaper in the UK doing a full story based on an internal chat between scientists. But this is what happened. And there it was there. We've got this thing, so many things. And I was already saying to people, come on, calm down a bit, okay? This is just a chat that you're reporting on. And then it blew up. Then we learned the backstory afterwards. The major increase in cases that was happening in South Africa was related to happenings amongst young people at universities. So, you know, young people, they have a tendency to gather and mingle, and we have very light restrictions in South Africa at the moment. And this infections were taking off. So many things were happening at the same time. Also, just a few weeks before then, we'd started adding antigen test results to a surveillance system. So information systems were in flux. Students were gathering, year-end parties were happening. A particular GP doctor was raising the alarm, and the British media was like making a noise. Communicating in the midst of all of this, it's a challenge. And I think that, like, I will accept the weaknesses of scientists and communicators. And somebody commented to me, you know, scientists are terrible politicians, and I would also accept that, because public health is also a good part politics. But when when the circumstances that I've just described happened, what were we meant to be doing?
Yeah. We have lots of questions already, and I have some questions, but I think I should take some questions from the audience. And so let's take this one. Professor Tomori, I think you can answer this question. How do you think the handling of the Omicron variant would affect how countries report new variants?
Well, thank you very much. I think, first of all, if in the hands of the politicians, they were likely to get no more reports. People are very sensitive with the outcome of what happened with this situation in South Africa. I don't expect the next one. In fact, I would be surprised if the government does not, in a way, call on the politicians to, I mean, on the scientists to get through the normal procedure of getting information out. For example, in Nigeria, the states actually more had a little bit of control, especially on the lab they built. And even though results are sent out to our NCDC, it's also sent to the state at the same time. Unfortunately, NCDC dare not put out that result until the state tells it either sanctions it. Sometimes the states reduces the number that they have because they're watching what is happening in other states and doing that one. Immediately we get ourselves involved with the politicians. You know, just like my colleague has said, there's need for us as scientists to learn, you know, to get the information out to people. But also, one, I think, important point for us is that we should not get ourselves involved in the politics. Like the issue with which I raised with the Botswana. Up to today, nobody can say specifically where those what do you call it? Those diplomats came from. And the question then was, look, they arrived on the 7th of November. You tested them on the 11th. Why did you wait for 4 days? All those kind of things. So these are issues that we as scientists must get ourselves involved in trying to understand and not get in the political side of it, but provide data and information, you know, as it is. I mentioned the issue where people then said, oh, you know, Netherlands had this since November 19, and you know why it was all over there, but they refused to report their own, that kind of situation. So we're going to get a situation where we have to for example, the experience of South Africa would definitely make people to say no. I mean, we'll keep our information until, you know, we see what is happening. You remember way back, that is not even right now. You remember way back in the days when they used to name viruses after the towns where they were found.
Yeah.
And that became a major issue. Up to today, there's a town in Nigeria, up to they see telling our government to go and change the name of Lassa fever to something else. 50, 60 years after that has happened. So I think this is what is likely going to happen. Over.
Okay. So many questions, and okay, I think it's the goal of this session is also to provide journalists with access to tools for you to use. So before I take another question, there is one tool that I would like to share with journalists that if you are interested in tracking updated information about where the sequences are coming from. So the tool is this is I'm sharing the link. The link I just shared is serving as a central database, open access system for sharing information around the COVID strains from different parts of the world. So if you look at, let me share my screen so I can show you how you can actually do this on your own. While I'm doing it, I think, Peter, you can be answering this question on how much effect this is going to have. I think it's something that people are really worried about. Asha Thomas would like to know, is this Omicron variant more virulent than Delta? And is third dose of vaccination necessary to fight this variant? Can you take that?
Okay, very quickly. So look, in South Africa, this thing was starting where Delta wave was already finished. So it's difficult to say. Is it more intrinsically virulent? In the UK, however, where they are overrun by Delta at the moment, we do see Omicron growing at a modest rate. I think, let's say 2% per week when I last heard from them. So it might be more virulent than Delta. It certainly seems to be quite virulent, okay? In terms of vaccines, there are hints that we will need third doses, but there have been hints for quite some time that we should consider things like the Pfizer vaccine a 3-dose regime. It's difficult to say so early on what all of this means exactly. And I think that the question was also asked, how will we communicate this need for boosters? Look, the one thing I will say as scientists, scientists make terrible advisors because politicians want an answer. How many vaccines do we need? What must I tell the Minister of Finance to buy? As a scientist, I will tell you what we know today is this, okay? And our evidence is that, okay? So what we need to communicate to people is that this is a new virus and a new disease. What we know we need today might change. What the tools we have for fighting this thing might change. And we need to be prepared to roll with the punches. And in terms of the communication around this thing, I think it's also to do what the experts on misinformation call pre-bunking, okay? The people who are spreading misinformation, there are people who are doing it because they're bad communicators. But there is a very well-funded network of people who've got something to sell you, who are spreading disinformation for profit, okay? We know this, those who've been tracking this thing. We know that when we're communicating, we need to let people know that, look, when somebody's out there saying, buy my potion, okay? There's even people in South Africa these days who will sell you a concoction where they say, this vaccine, if you have a regret that you took it, buy my my treatment. There is no need for such a treatment. It's nonsense. But you might have noticed those phrase, buy this, okay? There's people out there who are making good money off their roles in the disinformation economy. And I think that when we're talking about booster doses, when we're talking about the need to get vaccinated, when we're talking about new treatment and all of those things, we need to say that, look, guys, we are not talking in a vacuum. It's not just us spreading the facts and then you're just waiting to collect them. We are talking in the midst of a lot of noise and static.
Okay. There's also an an issue that I think is really worth mentioning. People always ask about whether Omicron is more virulent than others. I would like Professor Tomori to take this much further about other factors other than the virus itself or the genetics of the virus that could actually be even contributing to the virulence of the virus, or is it just the virus alone that determines whether the disease will be more severe? Are there other things that could be contributing to the virus more virulent in one part of the world to another?
Yeah, I think the status of vaccination is the first thing that comes to mind. Obviously, the person who has not received any vaccine at all, or the one who has received only one dose of a 2-dose vaccine, the level of immunity or protection is obviously, the one that has not gotten at all, it has no protection. And therefore, that an Omicron or something coming in, the Delta coming in, we expect that such a person will have a more severe infection. And in the situation in the African region where, very few, the percentage of of vaccination is really very low. This worries one in particular. To me, I think most important factor is the level of immunity in the individual, whether you receive 1 dose or 2 doses or whatever it is that you receive. Again, the type of vaccine you receive. Some of these are the factors to me that will affect the virulence, or what you like to call it, the severity of infection of a variant.
Yeah, thank you, Prof. So the link you have on what you have on your screen is actually the landing page for the link I just shared. I want to show you how you can track reports from different parts of the world, especially from your country. So if you click that link, you come in here to GISAID landing page. Then there is one here that they show track Omicron and other variants. So what you just do is that you click that particular aspect, and it pops out. The way this was developed was different scientists, different countries are contributing, they are sharing their information. So instead of waiting on your minister for health or running after any journalist, any healthcare professional, any healthcare experts to know whether your country has reported Omicron or not, you can just go into this database and quickly access information. Yeah, I'm trying to just, okay, it's coming up now. So you can see the breakdown here. So so far, if you look at the country count, okay, up here you have the Omicron, but you can actually change it to search for other strain, other variants too. So you pop it up. If you look at it, you can see there is the Omicron that has been clicked, and you can see the countries that have already reported the variants here. So it's something I will encourage you to play around with, check it out, and look at what the situation is in your country. And talking of situations in one country or the other, Peter, there's something I also want. There is this debate around how to convince individuals to actually go for the booster shots. We have individuals that are already afraid of needles. Even before COVID came, they grudgingly accepted the first dose. Some grudgingly accepted the second dose. So, from a scientist point of view, how do you still convince such people to still go for subsequent doses? And when we are already dealing with misinformation, is there a clear-cut way to be able to determine and predict, okay, this is the total number of shots that will be required to fully protect people?
No, there isn't. But look, we have this. Look, I mean, I will challenge people. Maybe the men will not know this, unfortunately, but the mothers will know. Like, how many shots did your baby get? You know, the number is quite some number. Okay, so we have two challenges. The one is the misinformation. We have to convince people to go. The other is the access problems. As Prof. Tomori was saying, it's, you know, we are still finding it difficult to get vaccines, and a vaccine you know, that is in maybe Abuja is not very useful if you're in Ede, right? Well, this vaccine needs to be right there where you are, okay? So we have to make it easy. We have to bring the vaccine effectively to the doorstep. And then on the other hand, we have to say that, look, the information on the safety of these vaccines, it has been looked at by so many different groups, okay? So if you go look at, for instance, the European Medicines Agency, they do a regular report where they investigate, you know, reports of side effects and things like that. And I mean, as we know, many more Europeans have got these vaccines than us in Africa, okay? Where the problems have been detected, you know, the very rare problems and that have been detected, they have been detected in these European groups. We have to reassure people that the evidence is there for the safety of these interventions, okay? I know it's not pleasant. You know, the thing about a vaccine, it's difficult to convince people, I'm feeling perfectly fine today, so now I'm going to let some guy jab something into my arm and then I'm going to feel like sick for the next day, you know? But we do this to our children all the time, okay? We need to fight to normalize the fact that, like, when you're dealing with an abnormal situation, a novel virus, a pathogen, then we deal with things this way, okay? However, I mean, I'd like to get the Prof. Tomorry into this as well, because we've been fighting virus preventable things for a long time. And I'm sure that his experience will have many more stories of dealing with a vaccinating adult when vaccinating adults was normal, okay? We've just got short memories to forget what vaccination campaigns look like.
Thanks. Thank you very much.
Yeah.
Okay, so Okay.
No,
Yeah,
yeah,
I
I
just
actually
mean,
wanted to bring you into that issue too. So, what
okay.
can you also add, convincing people to be
Yeah, you see,
vaccinated?
he raised quite a lot of important issues. The point is that we need to get, first of all, I think one of the things we need to look at, there are two things in the African region, or everywhere, anywhere, that the information we have, we only have as much information based on what is there. So we don't have all the information. I think we need to come up front and inform our people that this is how much information we have. And then compare with the experience of the others. You look at yellow fever, for example, over years that they've been using it, they now said every 10 years, go back for. Each vaccine differs, each virus differs. The type of symptom you get from yellow fever is different from what you're getting from COVID. And we're learning, we're still learning along the line. And so people must be able to say that there are no, one of the greatest disasters that I think happened to, well, to COVID, not disaster, why we don't seem to have any due regard for COVID. You remember, death appeared to be the hallmark for COVID infection. When the whole thing started at the beginning, the Bill Gates and the others, Africa, everybody, you're going to see dead body on the road. You're going to see all that kind of thing. So it became the mark for COVID infection. But then when we didn't see it, of course, then it meant there was no COVID. But yet there are other stages along the line. This, I think we need to also go back into history and correct some of the perceptions based on this, and accept that we didn't know a lot about this. The epidemiology of the disease in Europe is different from the epidemiology in Africa. And these are the kind of information we as scientists need to begin to point out to our people and that kind of situation. Back to the point you said, when an epidemic is raging, it was easy to go get people to get to yellow fever. When you see people right there dying in your presence, nobody will tell you to go and line up for the vaccine. But unfortunately, it's not the same with this one. Most people are having especially the young ones, they're having asymptomatic infection. They don't even know they have it. So why would I go and get something? Whatever. So I think these are some of the points that COVID differs from those other big diseases like yellow fever. You also mentioned, my friend, about the fact that mothers know better about this type of thing. The multiple injections that you get, so it's understandable. But that is something associated with children. And you don't, I mean, how many vaccines do you give except for this epidemic? Adults don't get vaccines anymore. So these are some of the areas that we need to begin laying it down step by step with our people, get involved into, get that kind of information. Even back in Nigeria, for example, we're using a lot for polio. You remember the time we used to have polio vaccine hesitation or total rejection. We needed to go back to the people closest to the people. I had my friend saying, if the vaccine is in Abuja and I'm in another place, it doesn't get to me. You have to get that vaccine into the people. So that, Peter. So we need to get that information, collect our own information, and be able to go to our people, go back and tell them there were errors in the past. And this kind of information is not so. This is what is actually happening. We now have more experience on those bases, but we still don't have enough. And therefore, so come out openly. Like I was telling our government at the one time, when you do something good on one side and you failed on the other side, provide all that information and tell them, I did this, yes. On this other side, we couldn't because of this reason. Then people begin to trust you. But when you now only report where you succeeded and then keep the other side, which they know that you need to succeed, they'll fill it with the rest of your fact, your own side, with the other one which will blow up. Oh, see what is happening here. You're only talking about your own. So I think as scientists and as people, whatever information we have, let us get all of it. And I mean positive, whatever knowledge you have, make it available to the people and let them know that we are not infallible. And these are the kind of situations. I think that's what we should be looking at. Over.
Yeah, so scientists are not infallible, governments are not infallible. Everybody, trust is really, really important to be able to convince people to come around for vaccination, especially like Prof said, when they are not feeling any symptoms. So I would like to take this question from Cyril from Cameroon. Cyril writes, are new variants like Omicron linked to low vaccine coverage in Africa? And why is this new variant making global headlines? How deadlier or contagious is the variant over the other existing variants? So Peter, I want you to break it down. No complex bioinformatics jargon. So can you give it a shot?
Okay, look, when the virus spreads, remember, when the virus is growing in you, it's changing. When the sum of that changing is going to the next person. So when the virus is spreading, it's changing. You get variants. Okay, we will get variants insofar as there are more cases. If we could stop the virus spreading, then there will not be any more variation. Okay, we've only done that with a very small number of viruses in human history. We know that smallpox has been eradicated. Okay, but now we stopped vaccinating against smallpox. You might have heard of monkeypox. If we had carried on vaccinating against pox viruses, we might never have monkeypox. Okay, but now we have cases, so therefore we will get new variants. If you look at other coronaviruses, the ones that cause a normal cold, so we're talking about 229E, NL63, those guys, okay, that you've never heard of, those code words. Those things are spreading all the time, they're changing all the time. If we had perfect public health campaigns that were able to get high quality masks to everybody, that were able to give people money to stay away from work when they're sick, that were able to identify every case as it came up, and that were able to vaccinate everybody in a short period of time. In other words, if we basically looked a bit like China and we just squashed this thing out of existence, okay, or Taiwan, then we would get no variants. We have failed at that as a world already. We have failed. So we are now living with variants. Now what? What are we going to do next? And I love what Prof. Tomori was saying. We must be humble. We must accept our failures. Okay, we probably failed by early last year to stop this virus ever existing again. So the original SARS-CoV-1 doesn't exist anymore. That thing was squashed out. Certain characteristics of the virus made it possible, and also certain hard work made it possible to squash that thing out. We've not squashed this thing out, and we know that given the failings of African health systems, given the failings of global solidarity that we're facing, we are never going to squash this virus out again. It's in too many places. Look, polio, okay? We've managed to almost squash it out, but it's taking huge effort, and we are having a really hard time. There are aspects of SARS-CoV-2 that make it exceptionally difficult to squash out, okay? So that means that it will carry on spreading, it will carry on challenging us, and we have to admit those failings and say, what is our next best solution? So vaccines, yes. Tests, tests that are $20 is a useless test for me, right? Because it means it's not going to be used. Masks, high quality masks, which are easily accessible. Okay, these are all of these things. Public health is a massive undertaking, and it's not an easy undertaking. These things are going to be necessary, and we're going to be fighting this virus for years to come. But with humility, with accepting our failings, and fighting for better. Over.
Prof, would you like to add anything to what Peter said?
Hello?
Yeah, Prof, I said, do you have any addition to what Peter said?
Yeah. I thank you, Peter. You raised all the important points. In fact, one of the things I used to ask people, I said, where are the variants coming from? Since Wuhan, have you found any variant from China? I don't know, maybe they're not reporting their own, but have we really? New Zealand, all those countries where they not only vaccinate their people, but also maintain the non-pharmaceutical interventions. These are the ones where we're not finding the variants, or maybe not the kind of thing we're seeing. Where are we getting the variant? Brazil, Africa, all those places where we're not following, where we're not vaccinating. That's what it is. You remember, I used to give we talk about mobile phones. Your phone is not mobile until you carry it around. Where you put it on your table, there it stays. So it's not mobile. You make it mobile. So also these viruses. We make the virus mobile. And as Peter said, the more they transmit between us, the more we create variants. And back all the failures that he mentioned on our own side and the inequity in the world is one thing is that now they vaccinated all their people over there, as many of them, All we need is new variant from areas where they are not vaccinated, and all their vaccines are turned to zero. So that is where, when we are talking about equity, we need to begin to mention those type of things. Yes, you are all protected. No worry, I'm bringing my variant to come and destroy all you've done. Simple thing like that. These are issues that we need to, it's real life situation, and we need to begin to bring up. For me, I think you raised that important point. It is important for us to continue to do the things that we're doing. Again, I keep praising our colleagues in South Africa. You are very well organized. And I think a little bit of that, a few other African centers, need to be that kind of organized. Otherwise, for example, why will it be that the first report of Omicron coming out of Nigeria happens to be Nigerians who traveled to Canada, and Canada detected it for us, and Britain detected it for us before we detected it? That's the problem. Those are the things where you need to begin to say, and to call our leaders, and get back to them. We are scientists. Let them understand this in this direction. For example, I was making a point the other day. You read about Africans who drown, immigrants who drown in the sea in Europe. Who is making all the noise about that? It's the European leaders. Has any African leader never come out to talk to you about why are people going over there? What is making them to go into those places? Why will anybody take all the danger to go across the Sahara Desert to go and drown in the Mediterranean? Isn't it a question? Say, why are they leaving? These are questions. Why are we getting all these insults, sorry to use the word, from outside the world? Because we will not focus on those things that will make us, there's many talents in the African region, but we're not creating the enabling environment to make full use of the talents we have. And that's some of the things that we as scientists also need to go back and tell our people, we can do this, provide this way for us, and continue to say it. It's not just one say it at one press conference, but continue to hammer it into the leadership that we need to create that enabling environment for the brilliant scientists we have in Africa to do great things for the good of Africa. Over.
My second to last question. Wow, lots of new questions are coming up. Peter, I wanted to address this. There are some articles, this from a participant. I'm reading the question. There are some articles stating that the vaccines are driving the evolution of more virulent SARS-CoV-2 strains. How likely is this? Peter?
Vaccines are not antibiotics, okay? So we don't get antibiotic resistance like we get vaccine resistance. It's, misuse of antibiotics drives antibiotic resistance. Vaccines, they're not driving there is no virus in the history of viruses that has been driven by a vaccine, okay? So that's what we do see is the kind of arms race between our immunity and the virus, if it still transmits, contributing, but we're not seeing vaccines driving new variants, because if that was also the case, again, following back to what Prof. Tomorry was saying, where are the variants emerging? Okay, they're emerging largely in the unvaccinated but infected populations. Over.
Yes, okay, thank you very much. Dr. Tom, Prof, do you also want to chip in one or two things?
No, he said it all. There's no more to add.
Okay, then I think this last question, I would like Peter to just provide any information regarding tools, not just specific data. So if people want to track, what are your real time sources for resources that any individual can easily access?
Yeah, you mentioned GISAID. There are other trackers like COV Spectrum and COV lineages, these things. You know what, Paul, let's take it up with a Twitter thread that we will follow up to this seminar that you can tweet out on that, okay? It's also important to realize that some of these things are quite difficult for non-experts to interpret, okay? The one thing is, I saw there was a question about severity. Give us time. I had a journalist call me a few days ago and they wanted to know definitive answers. I said, to really know about the severity of this virus, we know it is still COVID-19, as Prof. Tomorry said earlier, in the unvaccinated, it's going to be a problem. It's going to be a serious problem for some people. And we know that the outcome is not only death or survival, it is also the so-called long COVID is terrifically prevalent, okay? But to really know how does this thing stack up in our population, we will need to wait for some time. And what's happening in South Africa with our near 80% seroprevalence might not be happening in other countries, okay? So give us more time. And don't push us to like have all the answers and then slam us when the answers were wrong. Look, we are over time, but I would like to end with just one thing. I know the prof said that we are scientists, not politicians, but in the world of public health, I mean, my Twitter profile, my pinned tweet says that I have a mission, okay? As scientists, I do believe that we do, that we exist in a world. Politicians decide who of us gets money. Politicians decide when are we allowed to release data to the world. Politicians decide what happens with our education systems, with our book clubs, with our science clubs, with our schools, what happens in our neighborhoods, who gets clean water, who gets decent housing, who gets toilets and all of these things, okay? So as scientists, I think that, you know, I really appreciate the opportunities that you've given me here, Paul, to basically be your neighborhood scientist, but also to be a bit of a firebrand, somebody who's always going to say that I will not take death less seriously, I will not take illness less seriously. And as a scientist, I will tell you which direction, but I cannot make you walk that direction in order to fight the many diseases that our people are afflicted with. So thank you very much for the opportunity to talk to people about Omicron. And I'm very glad that our conversation could go in quite a broad direction. Over.
Yeah, Professor Tomori, how do you see COVID-19 ending?
It will be an, what do I say, who will predict how it's going to end? So many factors coming on, which none of us can predict. I mean, people's behavior or something. I raised one point to appeal. There was a time I was talking with some of the government officials. I think the greatest mistake that our governments made was to assume that they were the one controlling the epidemic. They are not. The people who are pushing the epidemic, who would be able to control it, is the individual person. Just like Peter said, if the virus gets into me, I wear my mask, you wear your mask, it ends in me. So we are the more important role player in the transmission of this disease. And so when those rules are there and we refuse to obey them, we are contributing to creating more problems. Incidentally, Peter, in the last recent survey we did, some of our states, we're getting 80% self-prudent surveillance in parts of Nigeria. And yet we are saying the cases are not occurring. I mean, so these are some of the issues, I think, messages we need to begin to put to our people. Yes, you're not reporting it, but the people are getting infected. Otherwise, you won't be getting antibodies, if they're naturally infected. So the point is that we need to engage the politicians, just like Peter said. I mean, unfortunately, that's what it is. You and I can work hard in your lab and do whatever you like to do. Translating it into the public becomes that of the work of the politician. And we need to engage them. We need to get back to them and let them know. So to your question, I think it would be foolhardy to say this epidemic is going to end next year or not. I use the word. I said this is one of the smartest viruses I've seen. Elusive, evasive, unlike one-man disaster machine, Ebola, piam, wipe past everybody, and that's the end of the story. This one, keeps adapting and keeps changing, keeps turning into something else. The symptoms we knew at the beginning is not what we're talking about now. So we are learning. We're all learning every day. This virus comes in one form or the other. And so anybody predicting that it's going to end tomorrow is gambling with.
Okay, Peter, for you, my question is not when, but how do you also think COVID would end?
Okay, yeah, we just very briefly, because we're running late, but the COVID, this is a question, I don't know how to answer. This is a question that is an active question. This is not a question that is one for predicting. This is not like next week's lotto numbers, okay? Then they're going to do something and then you'll get lotto numbers. You can't do anything to impact that, okay? So, I'm sorry, I was never a COVID person. I was never even a virus person before 2020. My disease was tuberculosis, Mycobacterium tuberculosis. That was my pathogen. Tell me, Paul, how is tuberculosis going to end? Okay, how is malaria going to end? How is typhoid going to end? These things are not going to end. We're going to end them or not end them. Okay? We're going to be honest. We're going to be forthright. We're going to fight these things, not put out the fake numbers, not pretend that like, people like us don't get TB, it doesn't matter. Not do all of those silly things. Not say that like it's okay if we find signs of typhoid in the Ibadan water supply, but we must just please not publicize that too widely. We will not do any of those stupid things. It will end when we make it end, and this is true. Do you find tuberculosis in London? Barely ever. Okay, it will end when we make it end, and it will end as the prophet said, it will, this virus is smart. There are aspects of this virus that make it extremely difficult to fight. I will rather be fighting Ebola. I will end that thing much more easily, okay? Even though it is a dreadful virus, okay? But for any disease, it will end when we make it end.
Fantastic. That's a way to put it.
Yeah, I don't know whether there is any other way to actually end this. Prof, do you have any last remarks?
No, I think Peter said it all. It will end when we end it. We are responsible for transmitting the disease, so we are responsible for ending it.
Yeah, and on that note, everyone, I want to appreciate our experts, Peter from South Africa and Professor Tomori from Nigeria, for helping us to make even much more better sense of the Omicron variant, which indirectly means that whenever the next variant is available again, I will send a message as I used to send it to Peter. That Peter, do you know what the name of the next variant will be? Do we have an idea of what the name will be already?
No, I'm not going to predict these future things. I mean, next thing you're going to ask me lots of numbers. Anyway.
Okay. Okay, no problem. So, like they said, it's a continuing conversation, which unfortunately might also still extend into the new year. And but as more information become available, I encourage you to also access it, update yourself, so that you can better inform your readers and your audiences, because it will be a very serious thing for journalists to also be contributing to the misinformation, and that is how it has been with us. So if you want to know more about the International Center for Journalists Global Crisis Reporting Forum, I encourage you to check out the website www.icfj.org, and to access more resources, please check out IJNet platform on www.ijnet.org, and I'll endeavor to get the slides from Peter, and I'm going to be sharing the slides with members of our Facebook forum. So if you are not part of our Facebook forum yet, please go to facebook.com and search for ICFJ Global Health Crisis Reporting Forum. Once again, go to Facebook and search for ICFJ Global Health Crisis Reporting Forum. And from me and the entire members of the ICFJ community, I say thank you very much for making this edition quite interactive, quite engaging, and we hope that you've been able to learn one or two things, and you've been able to expand your body of knowledge regarding this COVID-19 pandemic and the Omicron variant in particular. So once again, thank you, Peter, and my prof, thank you very much. I appreciate both of you. Thank you for your wealth of knowledge, and thank you very much, and have a lovely day.